figure that you see on the screen is the amount of money that an American hospital had to pay when a patient's family sued them for wrongful death. While the figure itself is alarming, the reason for the lawsuit is even more so. The lawsuit was brought by the family of a patient who eloped from the hospital and then fell to their death while trying to scale the fence on the hospital premises. It's an extreme situation, but it very accurately depicts the potential dangerous outcomes and risks to patient safety that patient elopement poses. Today, my team and I are going to present our work on the issue of patient elopement in the Department of Surgery and how its risks can be mitigated such that dire situations like these never occur.
So following is the problem statement which was given to us. In simple terms, it is concerned with minimizing the occurrence of unauthorized patient departures, also known as patient elopement. Our initial understanding of the problem was like elopement means simply a patient running away. But after talking to our host, we got to know that it is not only that, but also patients leaving before triage, also patients leaving mid-treatment before the official discharge, and also expressing desire to leave the they want to leave the unit because they want to and because they are facing some symptoms.
So after we understood the technicalities of what elopement entails, we wanted to understand exactly why elopement is such a severe issue and what kind of impact it's having on the concerned stakeholders in our problem. And we discovered that the impact of elopement is twofold. First, the impact on the patients themselves, and the second being the impact on the hospital and the staff members. So for the patients, the main impact of elopement is that they leave with incomplete medical treatment. So this could mean that they leave with IV lines or PICC lines still in there attached to them, and if they handle it outside of the hospital premises themselves, they could injure themselves seriously. Or it could also mean they leave without the prescriptions or the medication that they require, and that could lead to health complications if their problems are not addressed. For the hospital and the staff, the impact arises from not only the distress of having a lost patient and sending out a search for the patient, but also from the potential monetary hit of if the patient has left with a costly equipment attached to them. So this understanding and developing this empathy of how the problem is impacting our stakeholders really helped us guide our methodology for assessing the problem.
So our methodology consisted of three main activities. It consisted of interviews with stakeholders, observations of the unit, and also analysis of the past elopement data. These three yielded us many different unique insights which I will further share. So we started by talking to a lot of stakeholders. We started with our host Sharon, then we went on to the search team, the risk management team, even the nurse practitioners, and also the service excellence team which tracks the visitor system. These helped us, like as and when we had a conversation with them, we went deeper into the problem, and it helped us break down the problem in the complex issue into smaller segments. The first issue I'd like to shed light upon is the training. I know that the nurses do their job incredibly well, but they are only trained for to treat the patient surgically. It is come to our attention that the majority of our elopement risk patients are like patients who suffer from substance abuse, but the nurses are not trained to deal with the patients who basically show withdrawal symptoms. At times it also happens that there are visual cues which the nurses are unable to take, and it is like they can show behavioral signs or something as simple as communicating directly to the nurse on their desire to leave. Not realizing this is one of the issues, I think. The next issue is communication lag. On most of the part, the nurses treat the patients, but it is also sometimes that the physicians and the consultants have a look at the patient. Sometimes it is like there is a important decision to be made, and there is a delay in communication because the nurses and physicians are not on the same page. This makes the patient agitated and maybe leads to unauthorized departure. The third one is the system. The hospital has basically a policy elopement document which has certain criteria, and it categorizes the patient as an elopement risk. Then like these criteria don't match the ones on the Epic system, and that's why there's a delay in maybe categorizing the patient as an elopement risk, and further it requires patient interventions during patient elopement.
So, through our observations in the Department of Surgery units in the Sheikh Zayed Tower and the Marburg Pavilion, we were able to find out what aspects of the hospital environment are contributing to facilitating patient elopement, and these have been divided into three main categories. The first category is the infrastructure and the layout of the hospital unit. Specifically for Marburg 2 and 3, we observed that there are doorways and entryways which have unrestricted access, so they do not have locks or they do not have swipe access. So for example, this doorway is one in Marburg 2 which remains propped open like this at all times, and it does not have a lock on it. It leads into a hallway which can connect you to essentially any part of the hospital building. So this is the hallway I was referring to from the door this way, and my teammate Aditya was able to take this route and walk all the way up to the entrance of the hospital despite having no prior knowledge of the layout of the hospital. So in Marburg 3 as well, there is a motion sensing door which opens simply upon proximity if it senses a person close to it. And while there is swipe access to come in from the unit, there is no swipe access to leave the unit. So it's an unrestricted exit point. And this door remains open for 30 seconds. So it leaves a lot of opportunity for tailgating by people who are technically not authorized to leave the unit. The second category is the surveillance technology in both the units. So Zayed and Marburg both have either a lack of surveillance or insufficient surveillance. Zayed 11 East particularly has no cameras in the unit, and for a large unit such as Zayed, it has a square-shaped layout. So without any camera monitoring, it is very difficult to track what any events that might be happening just around the corner or across a long hallway. The only camera at Zayed 11 East is outside the entry door. It's a doorbell camera, so that's the only time that any surveillance is being done. In Marburg 2 and 3, there are cameras in both the units. However, they have significant blind spots. For example, this is the surveillance monitor at Marburg 3, and here in the bottom frame is actually where that motion sensing door that I was talking about, but this frame, the door is beyond the coverage and you don't see actually when that door opens or when people get close to it. So there are blind spots in the surveillance system which need to be addressed as well. The final piece of this observation puzzle is the security. So right now, there is a widespread shortage of staffing in various departments in the hospital. But what stood out to us was that the security personnel that they already have, could be used way more effectively for the purpose of elopement prevention. For example, in both Marburg and Zayed, there are large unsupervised areas such as this lobby just outside the Zayed entrance, which sees a lot of foot traffic, but there's no security placement there, and the nurses have too much on their plate to be keeping track of the comings and goings in the unit. So these unsupervised areas would definitely benefit from an extra pair of eyes and ears to keep track of who's coming and who's leaving from the unit. And so these were our observations that helped us sort of figure out what pitfalls there are that we can cover. And Yash will now talk about some of the data that we were able to analyze.
So we analyzed elopement data from the past year, and we were able to identify different problems in various aspects. This data was describing each and every case of elopement in detail that happened over the past year. So you can see that we have identified 4 issues related to different aspects. The first one being problems with sitters. Sitters are people who are appointed to keep an eye on the elopement risk patients. They might be in-person sitters or tele-sitters who keep an eye on the patient virtually. So there are problems with sitters, like they might be unavailable sometimes, they might go for breaks, or sometimes they might not be able to identify certain cues from the elopement risk patients. So there were about 18% of such cases where there was some problem with the sitters. Coming next to the shortage and lack of training for the security guards, as we have mentioned earlier, that security guards are only present at the entrance of the hospital and not at the entrance and exit of every unit. And also there were some cases where security guards were not able to identify that certain protocols related to elopement patients. So there are about 28% of such cases. The third one being infrastructure issues, like we described earlier, that there are certain doors with no locks or no swipe access, some automatic doors and some blind spots with the cameras. So there are about 18% of cases that happen due to problems with the infrastructure of the units. And lastly, the highest contributor being 36% of cases coming from gaps in communication with different units, as well as problems with some procedures for elopement risk patients. So from this data analysis and our observation and our interviews, we have changed our problem statement, we have revised it, which Chongao will now share with us.
Okay, according to our observations and data analysis, we noticed that many of our major problems were related with patient enrollment or due to external factors. These factors either created or left opportunities open for patients to try eloping. So realizing the extent of these outside influences shift our focus from primarily looking at the patient to examining the environment. So there's a switch from patient-centric to environment-centric. Therefore, we have both short-term and long-term recommendations. The short-term recommendations are those can be applied and start functioning in a short period of time, also with a relatively lower effort. So the first one is to implementing locks and swipe access on the crucial doorways, which currently allow anybody to open. And for example, like our host was blocked on the way coming here. So this actually is very good. We want more locks to prevent patients from leaving the units without any detection. The second one is to setting up the surveillance system as well as enhance the existing ones to cover all the hallways in the unit. So currently there's only a few cameras, or especially in Diet 11E, there's no cameras. So placing the cameras effectively will add stuff in overseeing all the hallways and react immediately when needed. And the last one is to adjusting the placement of the security staff in order to have a continuous observation of the high traffic zones. Like as of now, the security staff only present at the front desk. They only are at the front desk. So strategically positioning them will help us to have a faster response when a patient trying to elope from the units. Additionally, we want providing elopement specific training for the security personnel to know how to and have a sense to get involved in those elopement. They need to know how to intervene in a happening elopement.
Now we have two long-term recommendations. The first one being training the care teams to identify when the SUDS consultation is required. So as Aditya told us earlier that majority of the elopement risk patients have a substance abuse history. These patients experience withdrawal symptoms and they get agitated and their desire of elopement increases exponentially. So when the care teams are trained to identify these sometimes direct, indirect and subtle cues from the patients of withdrawal, they can actually bring in the SUDS team, which is the Substance Use Disorder Services team, and this team can get the right resources to the patient at the right time, and this can actually help the patient address their underlying problem of substance abuse. The second one is establishing a crisis response team. As of now, for an elopement risk patient, the course of action of treatment is taken, the decisions for the course of action of treatment is taken by considering opinions of multiple teams. This is done by the nursing team one by one by reaching out to them, and this takes a lot of time and delays the treatment of the patient. So having a crisis response team which has individuals from each of those teams can actually speed up the process, and they can take a decision unanimously, and this will get the right treatment to the patient very quickly and reduce the time in which the patient can elope. And based on these long-term and short-term recommendations, we have also next steps for the implementation of these recommendations.
So now that we have seen the short-term and long-term recommendations, we have come up with next steps which the hospital can start with just to set the ball rolling. The first one is the placement of security cameras in Marburg and especially Zaid. They can start by contacting the vendors and technicians and place the cameras in such locations where they leave no blind spots. The second is the fire safety compliance. It is basically they can start assessing the fire safety regulations to ensure compliance on the installation of security doors. The third one is the placement of security in maybe a unit just to make sure and monitor that no patient elopes. The next long-term recommendation, the next steps for the long-term recommendation is basically defining the roles in the crisis response team and the number of members it should have and what exactly the task will be. The second one is the department can start taking consultation from the search department on what specific kind of information and education they want to give to the nurses. I'd like to conclude by thanking our host Sharon and the nurse practitioners who have joined us via Zoom, who have helped us in the entire journey. I'd also like to thank Trevor who kept guiding us in all these 7 weeks, and not to forget our project TAs Ronak and Kavya who made sure that we stayed on track whenever we lost path. Thank you, and we are open for questions.